how much of a role, and we can dive into the placebo of things, but how much of a role does placebo play in, or in nocebo? We could definitely dive into
Mhm.
both of them. Play in chronic pain, injury, just dealing with that for seemingly most of people's lives.
Yeah, I think it plays a huge role, especially when you talk about situations like that where pain's been around for a longer period of time.
Mhm.
Beliefs just play such a big part of it, both placebo and nocebo. And most people are aware of placebo, where if you believe something's going to help you, it will help you.
Yeah.
But the other side is nocebo, and that impacts a lot of people when they come into the clinic where they believe something harmful and it ends up causing something harmful in their body. And
Hmm.
so there are all kinds of neat studies out there like this where, of course, there are the kind of placebo studies where they tell people like, oh, this pill is going to help you, or this
Right.
intervention. And it's really, it's a placebo type pill. There's nothing to it. It's like a sugar pill. And
Hmm.
they do surgeries like this where they'll tell people, they'll tell people, they'll take two groups and they'll say, one of you is going to have the real surgery and one group's going to have the fake surgery. And so they do this on meniscus surgery as one example. So they take all these people who have meniscus tears on MRI. They have a meniscus on, they do an MRI and they all have a meniscus tear. And so they tell them you'll either be in the surgical group or you'll be in the kind of sham, they call it a
Hmm.
sham surgery. And so that the people don't know for sure, when you have a meniscus surgery, they'll do it arthroscopically and they put these little portal kind of sites in your knee.
Yeah.
So after surgery, you'll just see these little kind of holes where they went in. And so everyone in the group has those holes put in, but only half of the group have the actual meniscus surgery. And what's interesting is at the end of it, everyone has similar reductions in pain. So that's another placebo example. But yeah, the other side is that nocebo, where if someone tells you something harmful, and a lot of times this unfortunately comes from different types of clinicians, and a lot of times it's unintentional, and we've
Yeah.
learned more about this over the years, but certain words, even the word chronic, we try not to use anymore because, and this kind of alludes to what you were talking about, sometimes this comes up with family history where you just believe because everyone in your family's had this problem, it's just inevitable that you're going to have this problem. And so chronic kind of falls in that category where we've seen in the research that they do these studies and ask patients about different words. And chronic usually means to people sort of that they're doomed and they won't
Hmm.
ever get better. And so now we use words like persistent instead, just to kind of speak to pains that tend to hang around and be a little more stubborn. Phrases like wear and tear, like sometimes doctors will say that people like wear and tear, or degenerative, like they'll talk about you have degenerative disc disease and your discs, they'll say you'll hear like 20-year-olds go in and have an MRI and they'll say, oh, your discs look like that of a 70-year-old. Those things can be really harmful. Like you see that all the time in physical therapy, that someone comes in and they've heard a message like that and they end up having more sensitivity and pain just because of the kind of fear, anxiety, and stress that message causes. So they're huge aspects. They really influence the pain system and how people feel. And a lot of the reason I got started on social media was frustrations around patients coming in and hearing those messages, and me just wanting to kind of push back on them and try to reframe pain for people, just to kind of reframe that whole conversation, because it's hard to see people not get better all the way because of their kind of mindset and beliefs around their pain.
Yeah, I think a belief or mindset people take on too is that once they've been diagnosed, it's kind of like they're reluctant to do anything about it, because once they've been given this, like, this is the problem, then it's kind of like, all right, well, now I know the problem, but I don't really do anything to move it forward, if that makes sense. Like, we almost feel powerless once we've been aware of an injury rather than doing something about it. But even going to the lens of rest, sleep, there's so many things that we have been told are for our benefit, but there's almost too far of in doing so. Do you find that that happens a lot in people you work with as well? As like once you've told them what the whatever it may be is, they're kind of like, okay, well, now it's up to you to figure it out, not me.
Yeah, that definitely comes up. There often is a mentality with people, kind of two parts to that, where when they've found out a diagnosis, sometimes people will feel like, oh, I don't have much power over this. They feel kind of
Yes.
powerless and like they can't really do anything. And so I think the message on that often is the musculoskeletal system is amazing. Your nervous system, plasticity in your nervous system, the ability of your musculoskeletal system to adapt. You and I were talking a little bit about progressive overload, which
Yeah.
anyone who's performed weightlifting at some point in their lifetime knows how much the body, the muscles and tendons can adapt when you slowly put more weight in the gym. Your body
Mhm.
can really become much stronger. Your bones become more dense. We have research showing your ligaments become thicker, the cartilage, your discs in your spine, the cartilage in your knees, all these things change when they look at studies on weightlifters versus kind of people who don't participate in that. And so I think one of the messages there is if you've had a diagnosis, don't let it stress you out too much because your system really can adapt with the right kind of stress. And some of these injuries actually won't change if you look at them on an MRI. Like an example would be like a meniscus tear.
Mhm.
Meniscus tears, a lot of people who are kind of middle aged have degenerative meniscus tears. And what's interesting about that is that when a person goes through rehab, they'll often get better. Their pain will go away and their function will go back to normal. But if you did a follow up MRI, the meniscus tear is probably still there because it's just one of those tissues that doesn't heal well. So I'm often trying to help patients understand that try not to be too focused on that thing that was found on MRI or X-ray. Don't latch onto that too much because it might not change that much, even though your symptoms will get better and your function will improve. It just the musculoskeletal system is more complex in that way. And a lot of these things actually exist on pain-free people. There's lots of studies where they take asymptomatic people with no pain, and they put them through an MRI, and about half of the population have disc bulges and disc herniations, meniscus tears, labral tears in their hip and shoulder, arthritis. So now we think of a lot of these things as just we just think of them as normal age-related changes. So you have to look at all of that with sort of a grain of salt. If you go have an MRI or an X-ray or some imaging study and a radiologist points something out on there, just don't stress it too much. It's just one piece of the puzzle. I'm always telling people it's just one piece of the puzzle. So I think that's a big aspect of getting a diagnosis. The other part, like you were talking about, sometimes people do have this mentality of I'm going to just go to this practitioner and they're going to fix me. I've got this diagnosis. I'm just going to go in, and they're sort of passive in their mindset, like, oh, just
Yeah.
I've literally had people come in and just say, I don't really care, just fix me. And it's such the wrong approach because in terms of the body, the things that have the best evidence are exercise and movement, which are active interventions. You have to participate in them. So if you come in with the mindset of someone else is just going to fix me and I'm not going to actively participate, you're probably not going to achieve the same outcomes as the person who's wanting to participate and be engaged. The chiropractor or physical therapist or whoever you're seeing, they can work on you. Like I'll do this sometimes. I'll work on people on the table. Maybe there's ice or heat put on the person. Sometimes in clinics they'll use electrical stimulation. You might go see an acupuncturist. All of those are what are called passive interventions, where it's something being done to you.
Yeah.
And that can help in the beginning, kind of help get out of acute pain. But once you move past that, if we look at the research, you really have to actively participate. And that's where things like mobility exercises and resistance training, strengthening exercises come in. Somebody can't do that to you. You have to do it. And it has the best evidence long term.